Thanks everyone for joining us, and we're going to be having a really interesting session thinking about DNA testing and dentistry. So let me introduce myself. My name is Kate Dack. I work within our regional Genomic Medicine Service Alliance as one of the educators. And if you go to the next slide for me, please. Let me talk you through the plan for the next hour. Next slide, please. So I'm going to do an introduction, and then Dr. Catherine Breen is going to tell you about her role as a consultant clinical geneticist. And then Ben McIntyre will share his expertise as a senior pharmacist in our group. So I think you've already seen these learning outcomes. So I can have next slide as well. These have been rolling around, the learning outcomes, but we're going to cover these three areas. So I'm going to talk about just a general introduction to the way DNA testing is used across the NHS. Catherine's going to talk about her role supporting families affected by genetic conditions. Ben will introduce this idea of pharmacogenomics, where we can look at the way we respond to medicines that's influenced by genetic variation. So those are the things we're going to cover, which is quite a broad range of topics, and it'd be really good at the end to hear your feedback on things you'd like to find out more about, because this is the very first time we've done any training on genomics with the dental workforce. So it'd be great to hear your feedback later on. So I'd like to start with a poll and find a little bit more from you. So I can have the first poll up, please.
Yes, it's just loading.
Takes a moment. Okay. It's just to find out about your awareness of genomics already. So on a scale of 1 to 5,
so that should be there.
Can everyone see it? How would you rate your understanding of the term genomic medicine? So 1 being you wouldn't say you have much knowledge, and 5 would say you feel confident, you've got lots of knowledge. Okay, so we see what the results are. I'm not sure where they appear.
They're in the chat, Kate, but I can relay them to you. They're actually still popping in their answers, but at the moment we have 50% on 1, 33% on 3, and 16% on 4.
Great. Right, well, let's move on to the next question. Thank you. That's giving us an idea that a lot of people would say they don't have, well, quite a mixture. Some people, the majority, saying they don't have great knowledge at this stage. So we have the next poll as well then, please. So this next one is about how would you rate your awareness of the DNA tests that are available out there? So 1 saying little awareness, and 5 meaning high levels of awareness. So it looks like the majority there is saying, again, they've not got that much awareness. So that's what we'd expected, that we're going to introduce things from the beginning and explain clearly what's possible. Right, thanks for doing those polls. So can we go on to the next slide then, please, Elaine? So we're going to be talking about DNA, and we hear lots about it. It's woven its way into everyday life now. And DNA testing is being used increasingly within the NHS, but sometimes it can be a bit hidden away, and maybe there are things that you're not aware of that are being done. So can I have next slide, please? This is just to get you thinking about, there's lots of different types of DNA tests being done. There's lots of things that are out there. I've put on there a few that are being used in dentistry, which I'll talk about in a bit more detail soon. I've also included COVID testing, because we all became aware of our ability to test the DNA of the virus when we're having PCR tests recently. And I've included on there lots of kits that the public can send a saliva sample off for DNA analysis. And that can tell you about your ancestry, or it can tell you about your predisposition to illnesses. Things like perhaps your risk of diabetes or heart disease or Alzheimer's. And just wanted to let you be aware that these tests are often looking for associations between DNA variants and someone's predisposition to an illness. So it will put you in a sort of higher than population risk or lower than population risk. And that can be quite sort of quite vague information it provides. But in contrast, when the NHS is using DNA testing, it's usually to reach a diagnosis where we've got clear evidence that finding those DNA variants is actually the responsible for someone's condition. So really, we have to look at different DNA tests separately and think about the utility of each test and what it's actually going to do to help us with the way we're caring for patients. And we can't really just think of them all as one because they're so varied and different. But please be confident, if the NHS is offering a DNA test, it's because the evidence has been reviewed carefully and we know that it's really got clear patient benefits. So next slide, please. So I wanted to just today get you thinking about the fact we can take DNA from different places to do the analysis. So often we take a blood sample or a saliva sample to check someone's genome, but you can also analyse the DNA of a tumour or look at the genome from an infective organism like in COVID. Okay, next slide, please. So when we are analysing DNA, what we really mean is we're looking at the structure of the DNA, and it's made up basically of a long string of 4 building blocks, which we represent by A, T, C, and G, which stand for adenine, thymine, cytosine, and guanine. And basically those different letters spell out instructions in our body to help our body know how to grow and develop and function. And if there's a change in the spelling, that changes the way our body functions. And you'll often see DNA sequence just represented as this long string of A's, T's, C's, and G's. And if you look at one little section of that DNA, because it's a large thing, if you look at a whole human genome, just one small section that's responsible for encoding one functioning protein in your body, and that could be an enzyme or a transporter or something structural. That's known as a gene, that one little section of the DNA sequence.
Sorry, I'll move out of the way on the CPD course this lunch.
So let's go on to the next slide, please. So this term genome is what we mean when we're talking about all of the DNA at once. So inside the cell of our body, inside the nucleus, you'll find the DNA packaged away into chromosomes. And when we're thinking about looking at a genome, it's looking at all of the genes and the DNA in between. And go on to the next slide then, please. So way back when I did my genetics degree, it was more of an era where we thought about single genes and the role of how one gene affects somebody's health. But we've moved on now into thinking about genomics because we can analyze the whole genome and understand how changes in our genome affect our health. Okay, next slide, please. It does feel quite Chris Whitty doing the next slide, please, all the time. So I just wanted to talk about how the technology is changing, really. It's dramatically changed over the last couple of decades. So it was about 2000 when the first draft of the Human Genome Project came out, and that was a huge international effort that took years and years and millions of pounds, whereas it's dramatically quicker and cheaper now. The changes in technology are phenomenal. And this little graphic shows you from just one person's genome, it's generating about 200 gigabytes of data, which is basically the capacity of a typical computer. So one genome is massive, and it's got lots of variants. If you compare one person's genome against a reference genome, you'll find lots of differences. So it's a complex job to understand when there's a significant DNA change that's affecting someone's health. Right, I was going to do a poll here, so let's try one quick poll. It's the last one, I think, in the middle. So can you set that up for us, Elaine?
Yes, just popping up now.
Thank you. So this is a question about DNA sequencing. It is just for you to think about can you guess what the world record is for sequencing a human genome? Doesn't matter if you get it wrong, it's just a guess. Well, you're all going for it. It's yeah, the majority of you are saying 5 hours, and you're right. It's pretty amazing. A group in Stanford in America have got the world record for sequencing a human genome in just five hours. And they think they can halve that time, it's mind-blowing that they can do that. It's not going to happen routinely for every patient, but it's possible now that the technology can be used to very quickly generate this whole genome and And amazingly, that group as well reached a diagnosis within 7 hours, they said, because they had a baby with epilepsy, they were able to find the gene, and then they knew exactly how to treat that patient. So it is incredible the way the technology is changing, and that does open up possibilities of how we can do more within the NHS. Okay, next slide, please. So I said already that I think it's important to remember that most DNA variants are not disease causing. They're just part of human variation, making us all unique individuals. But occasionally just a single letter change in the DNA sequence can really have a dramatic effect on someone's health. And equally, you do find sometimes patients who've got, or individuals who've got a deletion in a chunk of DNA that seems to have little effect on their health. So it's a complex job to interpret when a DNA change actually will affect someone's health. Okay, next slide, please. So this little diagram just gives an overview of how DNA testing can benefit patients. It comes from a recent NHS Genomic strategy. And basically on the top half, it's showing that DNA testing can help us identify people at risk and improve the way we can make a diagnosis. And the bottom half is showing that DNA testing can help us identify the most effective treatments and identify when people might have adverse drug reactions or their eligibility for clinical trials. So there's a real range of ways that DNA testing can help people in the NHS. Okay, next slide. So this is just one example of the way genomic testing is helping patients. These are babies all with neonatal diabetes. And in the past, they would have all been given the same treatment, and that wouldn't have worked that well for all of them. But now by analysing their genome and looking at, I think it's more than 25 different genes, we can understand for most of those babies the underlying cause of their diabetes, and then give them different treatments that will be far more effective. So that's a really powerful way that we can use genomic technologies to help these babies with. Okay, next slide, please. And in the world of cancer, genomic testing has made a huge difference. So we're able to identify DNA variants that some people have that put them at a high lifetime risk of developing cancer. And then other people will acquire those DNA changes during their lifetime. That's what happens for the majority of people. They're not born with DNA changes. They acquire those DNA changes during their lifetime. And one thing that's possible is often to analyse the tumour, we can understand more about DNA changes that are causing that, and that what treatment will be most effective for those people. So that's just some of the ways that DNA testing can help patients. Just next slide, please. So this diagram, on the left, it shows the group of patients who, like I said, sometimes about 5% of people who get cancer were born with gene changes that put them at higher risk of developing cancer. And that's something that they've inherited, and they'll pass on to children as well. So people in that position are seen within the Genomic Medicine Centre where Catherine works, because it's important they get access to screening from a younger age, and an extra more frequent screening as well, and also advice about ways they can reduce their risk. So for those patients, that DNA testing is really valuable. And like I said, the patients on the right hand side who have acquired DNA changes during their lifetime, they'll also benefit from the DNA analysis of the tumour, which can often help identify the treatments that's likely to work most effectively for them. Okay, next slide, please. And it's a big area, oncology, but I'm just trying to give you a taster of some of the ways that DNA testing can make a difference. And I thought it'd be really interesting to highlight this big research trial that's underway. Can we go next slide, please? It's all about trying to detect cancer early. So it's a big trial called the NHS Gallery trial, and they're collecting blood samples to see if they can find DNA they've broken away from cancer cells. It's already underway on quite a big scale, and we're yet to see its research. We don't know how well it will work, but it's looking hopeful that this might help in the way that we can do screening in the future to detect cancers, things like head and neck and throat cancers that typically become more advanced before they're detected. So those harder to detect cancers could be screened for using technologies like this. And as the chief exec of NHS England said, this could be the beginning of a revolution in cancer detection and treatment, because obviously the outcomes are so much better if we can detect cancer at a much earlier stage. So I just wanted you to be aware of that type of DNA testing that's being researched as well. Okay, next slide, please. So thinking of you as dentists, you might be aware that some practices in the country are offering DNA saliva testing. I found this group in Taunton who are very enthusiastic about it, and they state that it's helping to check someone's susceptibility to diseases, including periodontal disease. So I couldn't find out much detail about exactly what analysis they do, but they're doing this routinely now. Next slide, please. There's also the option that patients can send off a saliva sample and have this DNA analysis done through companies like Circogene offer this test. And this is about testing the oral microbiome and estimating a patient's bacterial load. So that's another option that patients might come to you having done a DNA test themselves and want to talk about what they've found out. Right, next slide, please. So I tried to think about how valuable these tests are and how they could be used in practice. And I got in touch with the British Society of Periodontology to get their advice. And they said that the commercially available genetic tests they're aware of tend to look for polymorphisms, and those are DNA variants in the IL-1 gene, which is interleukin-1 gene, which is part of the inflammatory process. And some claim this increases your risk of periodontal disease, but we've concluded that this test is almost worthless, as even if you test positive for this IL-1 polymorphism, there's very little you can do or tell the patient to do differently beyond normal good quality prevention. So they've obviously given us a lot of thought and decided that actually it wouldn't really be that valuable to find out if a patient has got one of those DNA variants. And then on the topic of bacterial testing, that was recently discussed at a BSP meeting, and it was unanimously agreed that commercial testing in practice has little or no benefit. That said, they are popular in the US and Germany. The commercial testing kits only screen for a low number of bugs, and they're not sensitive enough to test for subgroups within bacterial groups that may or may not be more pathogenic. So their conclusion was, while some sorts of tests for periosusceptibility or disease activity would be useful, it is actively being worked on, and there are no useful commercially available tests that the BSP recommends. So it's really valuable to know that you can get in touch with the BSP if there are things that you come across or there are new developments and you think, well, how useful is this test? How would I actually put it into practice? They've obviously given it a lot of thought and assessed the evidence. So it's new things do crop up, and I think it's really valuable that you can refer to them to get support about how useful it would be to you. Right, next slide, please. So my final slide is just to give an overview about the way the NHS has organised genomic services. So we're organised into the 7 regions, and within each region, there are genomic medicine centres where patients visit the clinicians, which is where Catherine's based. There are also the labs, the genomic laboratory hubs, where the DNA is analysed. And then there's the Genomic Medicine Service Alliance, which is a small team, and we're looking at the way genomics is being used more widely in the NHS and running training and research and transformation projects to support that. But ultimately, we all work together to try and support families who are affected by genetic conditions or anybody that will be having a genetic or genomic test. So I've whizzed through a lot of different areas there, but I just want to give you a taste of different things that are going on. Next slide, please. Were there any questions anyone wants to ask at this stage? I know we're not got a lot of time. I feel like I've overrun a little bit, so maybe we should just move on to the next speaker, and then we can take any questions at the end. Oh, it's great for me to be able to introduce Dr. Catherine Breen. She trained initially in paediatrics and then went on to specialise in genetics. So she'll give you a good overview of what happens in the clinical genetics team.
Thanks very much, Kate, and thanks for that really good introduction. So it's nice to meet you all. As Kate says, I work as a consultant geneticist. I work in one of the genomic medicine services, which I'll talk about a bit more in a sec about what we do. And that's my sort of day job. And then I also work as Deputy Clinical Director for the Northwest GMSA. We're trying to make access to genetic testing, like Kate says, just more equitable and available to everybody who needs it. So next slide, please. So the NHS in England has organised genomic services a little bit differently in the last few years, and some of what I'm talking about is relevant to across the UK. I don't know if some of you are perhaps based in Scotland or Wales or Northern Ireland, but in England there are sort of aims for the genomic medicine services, and this was based on the lab reorganisation that was done a few years ago. So the idea is that we're going to provide consistent, equitable care for the whole population. And that was made more possible by the advent of the National Genomic Test Directory, which again is available in England. And it means that all the tests that we can do as a genomic service and as other services, so other people working in other specialties, is available in one place, and it's defined who can have that test and who can request that test and what type of technology will be used to deliver the results. And one of the ideas is that as part of this increased testing, we can build this national genomic knowledge base. And that's partly because for the first time, the first health service in the world that can offer clinically a whole genome service is the sequence is the NHS, and we can offer that standardly. So when I see patients in clinic, that's one of the first tests now that I can offer to a patient is their whole genome to be sequenced. Next slide, please. So the clinical genomic services, as Kate's already said, there's a sort of been a shift from calling our services genetic services, which some of you may well have been familiar with over the years. We were previously clinical genetic services. And what do we do? So our sort of bread and butter is diagnosing genetic conditions, and that is usually through, particularly these days, genetic testing. And we really focus on choosing the right test for the right person, and that has to be at the right time. And that can be complicated by all manner of different aspects. For example, sometimes we offer testing to people before they've developed symptoms of a condition they know to be in the family, and that really requires very careful counselling to decide the right time for that person to have that test. A big part of our job is assessing a risk for a patient in front of us or for their family members of developing or inheriting a genetic condition, and we see patients before and during pregnancy to discuss those risks as well. And we also act as a sort of coordinator once the diagnosis has been made to refer people for treatment or for further management with genetic conditions. And again, as Kate has alluded to, a big part of our role is counselling. So that counselling might be around risk, but also around sort of dealing with the impact of being diagnosed with a genetic condition, which can be large, and there can be a lot of emotional overlay to the diagnosis for the person who's sat in clinic, because it can mean that their family members, for example, are at increased risk, and there's a whole sort of extra layer of complication to being diagnosed with a genetic disorder compared perhaps to some other disorders. Next slide, please. So the way that we do this is by working in a team, and we have some people like myself, clinical geneticists. We work very closely with genetic counsellors, and we also work together with our laboratory colleagues, again, to make sure that those results are correct, the right tests are chosen, and they're done in the right sort of time frame. And there's a whole host of other people that also need to be involved to be able to deliver the excellent service that we aim to. Next slide, please. So, as I said, all the genomic medicine services across England are linked with one of the genomic laboratory hubs, and there are 7 of those across the country. And we see patients of all ages. So, as I said, we see patients from sort of thinking about pregnancy to old age. We see children of all ages as well. And each centre across England covers a population of about 1 to 5 million. That's the same actually across the country, more or less. And our departments are usually based in a large teaching hospital, but we deliver peripheral clinics. So for the region that we cover, we also try to see patients closer to their home, because often our hospitals are a long journey away. So I work in Manchester, and some of our patients live in Lancaster, which is a 2 to 3 hour journey for them to get to us. So, for example, I go up to Lancaster once a month and deliver a clinic there. We accept referrals from all health professionals, including dentists. We don't get referrals all that often from dentists. We tend to get more perhaps from dentists who are based within, for example, the Children's Hospital, where they've seen patients who they suspect might have a genetic condition or know about a family history of a genetic condition and have referred the patient in for our advice. Some of our clinicians have special interests. That's probably true for most clinicians. So, for example, I see mainly patients with developmental disorders, and that includes adults and children. And if you're thinking about referring a patient or just out of interest would like to know where your local clinical genomic service is, there's an excellent patient support group called Genetic Alliance who lists all of the services across the country, including which areas they cover. And it's easy to find your local service there. Next slide, please. So I just thought I'd highlight a couple of cases, so a couple of patients who just illustrate where sort of we work together with our dental colleagues. So case one is a man in his 30s with a mild learning disability, and he'd also in adulthood been diagnosed with mental health problems, including schizophrenia. He'd had a small ventricular septal defect identified as a baby, and this had complicated some of his dental procedures in the past, as there had been queries about whether he needed antibiotic prophylaxis. And it had been noted that he had an unusual nasal sounding voice and facially appeared different to his family. So from a dental point of view, he had dental caries and an enamel defect, and during examination, a bifid uvula was noticed. Next slide, please. So some of you might have already guessed that this gentleman has a condition called 22q11 deletion syndrome, which used to be known as DiGeorge syndrome or velocardiofacial syndrome, which might be more familiar to you. And this is a highly variable condition, affects probably about 1 in 2,000 people. So it's likely that over the course of your career, you may have met somebody with 22q11 who may have known about it or may not have known about it. People can present as babies with congenital heart disease. Palate problems can be significant and noted early, but they can be much more subtle and just be VPI, which can be noted later on in life or, you know, in childhood when perhaps there are sort of speech enunciation difficulties. They can have hypoglycemia, particularly in the newborn period, and this can cause seizures. Learning issues are very common and they're usually mild. And it's what we call an autosomal dominant condition. So it can run in families, but most people are the first person in their family to have the deletion. And it also causes a whole host of other difficulties, for example, autism, or about a quarter of adults with the deletion are diagnosed with schizophrenia. Next slide, please. So the dental features are problematic for people with 22q11 deletion. Dental caries is really common, and enamel disorders are also very common. There was a study recently in Australia that looked at a good number of patients who have 22q11 deletion syndrome and particularly focused on their dental presentation. And what they found was that the presence of the disordered enamel correlated with a history of hypocalcemia. So not all patients with 22q11 deletion have a low calcium, but when they had, it really did seem to impact their dental development. And there are consensus guidelines available for 22q11. It's a complex multi-system disorder, and perhaps if somebody was visiting you who had the condition and you wanted to look up what the implications of some of the other problems might be, I would highly recommend the consensus document that's available through one of the patient support groups called Max Appeal. Next slide, please. So the next case I thought might be helpful to talk about is a child who's got a diagnosis of a condition called mucopolysaccharidosis type 4A, which is also called Morquio syndrome. And this is a disorder that's diagnosed in a different way. So Kate was talking about the sort of different technologies that we can use now in the NHS. So 22q11 deletion syndrome I've just talked about can be picked up on a very detailed check of the chromosomes. And this condition can be picked up biochemically and then confirmed with genetic testing to look at the gene that's involved. And it's another multi-system disorder, so affects multiple different parts of the body, but it's due to an enzyme deficiency. And what happens is having that enzyme missing means that there isn't the normal breakdown of glycosaminoglycans in the tissues, and that includes in the teeth and gums, meaning that deposits of those occur throughout the person's life. It's a very rare disorder. It's autosomal recessive, so different to 22q11 deletion. And it generally causes a profound difference about the skeletal development, again, because of this glycosaminoglycan deposition. And people have severe short stature. So in the sort of classical form, people in adult life are generally less than 120 centimetres tall, and they have lots of differences about the skeleton that cause multiple difficulties. This can cause cervical spine abnormalities as well, and a lung disease. But life expectancy significantly improved over recent years, and that's because of multiple differences in management. And next slide, please. So in MPS 4, patients have unusual teeth, so they have small, widely spaced teeth. There's some pictures there from a paper that's from a couple of years ago, and these are the really sort of typical features of this disorder. And the sort of abnormalities are thought due to the direct deposition of the glycosaminoglycans in the gums and teeth. But some of the other complications that you might come across if you met a patient with MPS 4 is that they can have an extremely challenging airway and C-spine instability, making examination and procedures very difficult. These days, for the last few years, patients have had access to enzyme replacement therapy. So that's an intravenous replacement of the enzyme that they're missing because of the genetic change they have. And in England, that's available as part of a managed access agreement. And what's hoped is that that will show improvements in lots of different areas of health. And there's a sort of question mark at the moment about changes to dental health in the long term. I just thought that was a sort of useful example of sort of the benefits of making a genetic diagnosis that might lead to a treatment and then hopefully better outcome in all systems, including people's dental health. Next slide, please. So in summary, as Kate said, we could really talk all day, I think, about genetic disorders that have dental manifestations. There are really so many, and no doubt all of you have met patients with genetic disorders and have known that they have the dental abnormalities they do because of their genetic condition, or perhaps they've been coincidental, but there's a definite lots of sort of joint working that can go on. There's a changing landscape with more and more diagnoses being made and treatments being developed. And what that means for us in genomics is that we're able to give more and more information to patients and families about things like the condition and the implications of it, and also about recurrence risk and any questions they might have. But it also means that we can make more tailored recommendations for patients, for example, about regular dental follow-up, for example. So, as I said before, we do accept referrals from our dental colleagues and requests for advice if needed. And if you want to have access further information about specific conditions, there's a couple of places I would recommend. So if you've got a patient who's coming in to see you with a genetic condition, then perhaps a good place to start is the NIHR website Gene Reviews, which has really excellent up-to-date information about all genetic conditions, and it includes very sort of systematic information. So for example, if there is a big impact on somebody's dental health, then there will be a section there in Gene Reviews about the dental management. And also patient support groups are a really good first source of information as well about genetic conditions, if you're interested. So thank you very much. Next slide, please. Yeah. Have we got any questions after that section? We've also got some time at the end, I think, haven't we, factored in, Kate, to answer any questions?
Yeah, we have got some time at the end, and I'm conscious of making sure we've got plenty of time for Ben's slides as well. So should we keep moving on, as I can't see anything else, any questions in the chat? Thank you ever so much, Catherine. Right, so now we're going to talk about the topic of pharmacogenomics, and I'm delighted Ben can join us. He's an experienced pharmacist with a special interest in genomic medicine. So over to you, Ben.
Okay, yeah, thanks, Kate. So yeah, just to briefly introduce myself, I'm Ben McIntyre. I'm a pharmacist here with the Northwest GMSA, and I'll be giving you a brief introduction to pharmacogenomics. So hopefully providing you with a basic awareness and understanding of what it's all about, how it works, and of course, most importantly, how it can improve patient care. Next slide, please. Just quickly in terms of what we'll cover, firstly, we'll just introduce some terms and definitions and concepts. We'll then examine what pharmacogenomics means in practice, mainly how it works and how it can benefit patients. I'll touch a little bit on pharmacogenetic prescribing guidelines, again, which many people may not be familiar with. And then we'll briefly look at how pharmacogenomics is relevant to some commonly prescribed drugs, and indeed one or two medicines which you might use in your dental practice as well. And then finally, we'll just finish on a quick patient case study to bring it all together at the end. Next slide, please. Okay, so you'll have heard previously that genomics is essentially the study of your body's complete set of genetic information and how that can influence health and disease. And similarly, pharmacogenomics is the study of how a person's genome can influence basically how they respond to medicines. And typically this could be due to some change in how a drug is metabolized, for example, a change in its therapeutic effect, or indeed how susceptible you might be to one of its side effects. Now, I should also mention at this point that you'll probably hear the terms pharmacogenomics and pharmacogenetics used interchangeably. That's generally fine. And in fact, pharmacogenetics is probably more correct, since we're nearly always talking about it in the context of a specific drug-gene interaction, rather than the impact of the wider genome on the drug. So hopefully that makes sense. To describe the effect of genetic variation on drugs in a bit more detail, so you'll know that pharmacology is essentially pharmacokinetics and pharmacodynamics. So genetic variation, first of all, it can affect or cause a change in the pharmacokinetics of the drug. So that might be via, for example, a gene that codes for a drug metabolizing enzyme. So one of the hepatic cytochrome enzymes, for example, or a transporter protein. This might mean that the drug is not completely metabolized so that it accumulates in your body. Obviously a consequence of this could be that you have more severe side effects, or you're more at risk of suffering from a particular side effect. It can also change the pharmacodynamics of the drug. So pharmacodynamics, of course, is the effect that the drug has on the body. So again, for example, if you have a genetic variant that means a drug receptor protein is not correctly expressed, or it's dysfunctional, for example, that drug then cannot bind to that receptor, or maybe it binds, but its effect is dysfunctional, for example. And then also genetic variation can affect drug hypersensitivity and someone's risk of immune-mediated adverse drug reactions, for example, by alterations in genes that code for HLA proteins. It's estimated that virtually all of us carry some degree of pharmacogenetic variation. So in other words, we carry a variant in at least one gene that influence drug therapy if we were to be tested. But it's important to note that variants in these genes for things like drug metabolizing enzymes or transporters may not have any effect whatsoever on a patient's life until such time as they're exposed to that drug, if that makes sense. So rather than someone who might carry a gene variant that puts them at risk of disease or a cancer, for example, in these cases, you can go through life essentially unaffected, but until that time that you're exposed to that drug. Next slide, please. So these are just some of the different ways in which genomics can inform and enable a more personalized or precision approach to medicine. So right away from some of the really novel and advanced therapies that you may be aware of, gene therapies and so on, but right the way down to some old drugs that have been around for years and decades even, and that we're now finding that we can repurpose or optimize using genomics. So you'll have probably heard about some of the, in the press and so on, these really expensive novel treatments using gene therapies. But in a lot of cases, they're used in obviously very rare instances or for rare disease where you might just have a tiny number of patients affected. But for the purposes of today, what we're focusing on is, as you can see just at the bottom of this slide, so it'll be using pharmacogenomics to guide our treatment decisions. And how we use it to optimize drug treatments and safety for patients. Next slide, please. Okay, so these next few slides will quickly look at how pharmacogenomics can work in practice and how we might want to implement it into routine healthcare. So we know that medicines are not effective for all patients. And we talked a little bit about how genetic variation can affect drug response. But of course, there can be many other reasons for this as well. It's not just the variants that we'll have in our genes. So genomics is just one way to identify these reasons. But for example, genetics can also be the reason or the cause of poor adherence, for example. So if you think about if a patient had a genetic variant, that means they experience a drug side effect. That might mean that they stop taking the drug because that side effect is intolerable or it's debilitating, for example, and they may not tell their GP or the prescriber about that. And so that contributes to a lack of adherence. So you can see then how the initial cause is that gene variant, and then it has a knock-on effect into other areas of medicine's compliance. And if you just click forward, please. Yeah. So if you think about the current model of care, so on the left of that little illustration, so what happens now currently is that a patient will see their GP, for example, who assesses them. They start a medicine, they prescribe it at a standard dose from the BNF, for example, and the patient goes away, they'll start taking it, we would hope. It may be effective, it may not, and they may have a side effect, as we discussed in that example. And then they come back and they may have that medicine, either the dose change, they may change to another medicine, and they're sent off again. And you can see how this is not really it's not an efficient process, for one. It's not a very satisfactory one for the patient. It uses time, it uses healthcare resource and so on. And it could be months or a year even, depending on what condition they're being treated for, before they arrive at a medicine that's really effective for them, that they can tolerate, that they don't have side effects and so on. But the pharmacogenomic approach, so on the right, what we hope is that they can have a pharmacogenetic test initially, whether it's, this is usually just either a blood or even a saliva test, at the very start of treatment, or preemptively, even before the start treatment. And that will inform or certainly enable us to choose the best medicine based on that for that patient, which should hopefully mean that A, it's more effective from the outset, and B, that they're less likely to experience adverse effects. So that's the kind of pharmacogenomic model, hopefully, that you can see. And of course, the beauty of this really is that it's a once in a lifetime test. Your genes don't change over your lifetime, your germline genes. So rather than for other drugs and so on, where you might need to get tested regularly or have kidney function monitored and so on, this is a once-off test, and once a patient has that in their record, that can inform future prescribing decisions throughout their lifetime. Next slide, please. So yeah, and when we talk about potential benefits that pharmacogenomics can give to patients, so this is just to give you a real world example, I guess, of the value of a pharmacogenomic approach to prescribing medicines. So there's lots of these type of studies out there, but this is one I chose just because it's one that was published earlier this year, I think, in The Lancet. So this was a multi-centre trial across several European healthcare systems, including the UK, where patients were preemptively genotyped for 12 genes with a known drug-gene interaction. And they then had their prescriptions subsequently adjusted according to those results and whether or not any variants were detected. These were then obviously compared to a control group who just received standard of care, so drug prescribed with no genetic test beforehand. And what it showed was that the pharmacogenetic intervention group had a significantly lower risk of adverse drug reactions. Somewhere around a 30% reduction in clinically significant ADRs. So this is a really, a clear demonstration, I think, of certainly from a drug safety point of view, and the benefits of this approach. And if you think about the number of A&E attendances and hospital admissions due to adverse drug reactions, it's estimated, I think the last figures I saw were about 1 in 15 admissions in the UK were due to an adverse drug reaction. And if you scale that across the NHS, it's a huge number. Of course, not all of these will be due to the genetic variant, as we discussed, but a significant proportion will be. We know that. So hopefully you can see the huge benefits that this approach would have in terms of patient safety, patient outcomes, but also in reducing our own healthcare costs and use of resources. Next slide, please. Okay, so I guess you might be wondering, as a clinician, how does pharmacogenetic testing work in practice? So if I order a test, for example, what does it look like? What does it mean? And so on. And because one of the big challenges of pharmacogenetic testing in the clinic is translating essentially a genetic laboratory result into an actionable or clinically relevant prescribing decision for you. So for this, I've just picked clopidogrel as an example, just because it's a commonly prescribed drug that has good evidence for using pharmacogenetics to guide treatment, and something, that it's not one of these novel or advanced or expensive drug treatments. It's an everyday drug. So on the left, just quickly, you'll see when the genetic test happens. So the enzyme, in this case, that we're interested in is called CYP2C19. So if you know about clopidogrel, you know that it's a prodrug, which means that itself it's inactive and it needs to be metabolized into an active form to have its effect. And it's predominantly metabolized by this CYP2C19 enzyme. So hopefully it makes sense that if that enzyme is defective or missing, for example, you will not be able to make the active drug, and therefore you will not get the therapeutic effect. So on the left is basically the raw genetic result, which for most of us is meaningless. And certainly as a clinician or someone seeing patients, that information in itself is no good to you. So that then gets translated into a star allele, as it's known. So essentially the nucleotide changes, so a G to an A or an A to G, for example, gets assigned a certain allele. That's just the convention in pharmacogenetics. And of course, because we have 2 copies of genes, this is then translated into a diplotype for the enzyme itself. But what we're interested in really is on the right, is what sort of phenotype does that correspond to? So in this example, with those allele changes, this would correspond to that patient being a poor metabolizer phenotype. So in other words, they've got a loss of function in this enzyme, and therefore they're much less likely to convert the drug to its active form. And as a result, the guidance would be that you might prescribe a different drug for that. So schematically, hopefully that makes sense about the whole process. What we want to know is the bits towards the end of this, where we just want a phenotype and some relevant advice that will tell us what to do. Next slide, please. So just moving on to prescribing guidelines, which are useful to be aware of. There's actually several hundred drug gene pairs that have evidence for pharmacogenetic guided prescribing. But obviously not all of these might have good quality or a clinically relevant evidence base, or at least not currently. But what we do have are explicit and established guidelines for 26 of these drug gene pairs. And these are just some of the selection that I've put up, but hopefully you can see that the wide range of drugs that can be affected by genetic variation, and also the genes involved. So you'll see a lot of them are the ones that we mentioned, the cytochrome enzymes involved in drug metabolism, but also other ones such as glucose 6-phosphate dehydrogenase, the HLA genes, again, as I referred to as well. And also highlighted there are 2 or 3 which would be relevant to dental practice, so analgesics such as non-steroidals, opioids, and proton pump inhibitors as well. Next slide, please. So when you look at the drugs on the dental prescribing formulary, there is actually quite some who have pharmacogenetic prescribing implications. So they're listed here with the corresponding gene that's involved. So just to note that the ones which are bolded have fairly robust and I guess clear prescribing recommendations, whereas the ones with an asterisk, so aspirin and diclofenac, they're also included in guidelines, but they have, I guess, less established or not good quality evidence to guide a therapy recommendation. So in these cases, you would just, they would be just prescribed as normal. Next slide, please. Okay, so what are these mysterious guidelines that I keep talking about? So the ones we usually refer to are CPIC. So this is the Clinical Pharmacogenetics Implementation Consortium. So just to be aware, these are it's an international consortium of experts that support clinical implementation of pharmacogenetic testing, and with the objective of helping clinicians I guess understand how genotyping should be used to optimize drug treatment. So it's important to note that they don't, it's not within their remit to say you should do a genetic test for drug XYZ. It's where you do genetic testing, here's how you interpret it, and here's how you should implement it in practice, if that makes sense. But these are evidence-based, they're peer-reviewed, they're published, and so on, and you can find them on online databases as well. Next slide, please. So the following couple of slides are just some examples from these where I've screenshotted and some examples where these guidelines would be for drugs that would be relevant to dentistry. So this is one for opioids that includes codeine and dihydrocodeine. So just to kind of look at the table here, just as an example. So this basically gives you your genotypes, the phenotypes on the left, and the frequency that these may occur in the population, and then the clinical implication rather, and a prescribing recommendation. So if we were to just look at codeine, for example, if they're identified as a poor metabolizer, you can see how you would have less effect because codeine, of course, needs to be metabolized to morphine. But in contrast, if you are an ultra rapid metabolizer, that will mean you will make a lot of morphine, which puts you at significant risk of toxicity. And the prescribing recommendation here would be that you avoid it due to that risk. And actually, this was the subject of a drug safety update a few years ago where this was identified. And it's actually found its way into the SPC for codeine, at least. I don't think it's in it for dihydrocodeine, but if you were to look at it, it states explicitly that codeine is now contraindicated in patients who are known CYP2D6 ultra-rapid metabolizers. Next slide, please. Yeah, and again, similarly, this is the guideline for non-steroidals. So again, you've got a phenotype, and in this case, it relates to CYP2C19. So if we were to look at, for example, a poor metabolizer, this means that there would be a significant increase in plasma concentrations of ibuprofen, for example, due to it having a longer half-life, and you can see then the patient would be at much higher risk of the occurrence of adverse effects or the severity. So in these cases, you would probably certainly avoid a non-steroidal, for example, or you might choose one that's not affected by the CYP2C19 enzyme. Likewise, if you had someone who was maybe an intermediate metabolizer, there's maybe a lower risk of drug toxicity. So this might, depending on the context and the patient, if it was a young healthy patient with no risk factors, you may decide, well, it's safe to use. But then if you had a patient who was maybe elderly or had a degree of renal dysfunction or previous history of GI bleeding, you would use this information added to the fact that they're an intermediate metabolizer, and you might decide to avoid the drug completely. And next slide, please. So finally, we'll just finish on a quick patient story. So I think a few slides previously, when I put up the list of drugs in the dental prescribers formulary, actually I was surprised to find carbamazepine was in there. I wasn't aware of that. I didn't think it was something that dentists would prescribe, but it is on the formulary. So this is quite instructive, this case study here, because this involves carbamazepine. So this was a young female patient with epilepsy who was prescribed carbamazepine, and due to the risk of birth defects, she had been put on this after previously being on valproate. So soon after she started it, she developed a mild itch on her arms, which progressed. Saw her GP about it, who initially just put it down to, I think, a reaction to a detergent or a washing powder. But she became progressively more unwell. She took time off work, essentially confined to bed with quite severe flu-like symptoms, with the rash progressing. And that was then found by her parents one evening, essentially unresponsive, and needed to be rushed to hospital. And when she got there, she was admitted to critical care. She had organ failure and significant skin loss. Fortunately, she recovered. But you may know this reaction. So what had happened in this instance was what's known as a Stevens-Johnson reaction, with toxic epidermal necrolysis and severe skin loss. In this particular case, this was down to this patient having a gene variant in HLA-B gene, so the STAR1502 genetic variant. And if you just advance the slide one click, please. Yeah, and this is relatively well known that this is quite prevalent in certain East Asian populations, particularly Han Chinese and Thai ethnicities, who carry this variant and are at a much higher risk of developing these reactions to carbamazepine and indeed certain other drugs as well. But this is just worth being aware of. I mean, this was the subject of a drug safety update over 15 years ago. So hopefully it shows that this is not some, pharmacogenomics is not a brand new concept or, some, novel technology. It's been around for a long time, and it's only really now that it's becoming more mainstream, and we're beginning to find more applications and uses for it and so on. So yeah, I'll finish there. Hopefully that's been instructive and it's given you a little bit of a flavour of pharmacogenomics. I'm happy to take any questions.
Thank you ever so much, Ben. That's great. There is a question there. Can you see it in the chat?
Yes, let me just flip to my other screen. Okay, so the question is, how or where could someone with epilepsy be tested for tailored drug treatment? As most treatment for this seems to be a stab in the dark and a watch and see approach. So excellent question. At the moment, I mean, you're right, that is exactly what happens for a lot of drugs. So with epilepsy specifically, so using the example that we just looked at, so for carbamazepine, it's part of the drug's license and marketing authorization that you should genotype certainly patients of, as I said, Han Chinese and Thai ethnicities for this particular gene variant prior to starting. So that is recommended. So that's fairly clear, and you can get that test. That can be done, you know, in our genomic laboratories at the moment. But for most other drugs, yes, there's only a small number of drugs. I think there's maybe 3 or 4 which are on the genomic test directory, which I think Catherine just touched on in her presentation. So these are tests that are commissioned within the health service that essentially the NHS provide for a small number of drugs. But yes, so patients with epilepsy and going on carbamazepine can get that test, but for lots of other ones, that test isn't yet available, primarily because there's probably either no evidence for it, and maybe there's not so much of an influence, you know, on treatment. But yeah, I mean, it's becoming more and more mainstream. As I said, I gave the example of clopidogrel, and that's now got or potentially will have a recommendation for genotyping for patients who have a stroke now, where it's recommended that they get genotyped prior to receiving clopidogrel. But yeah, I would expect, you know, in the years to come, we will see more and more drugs with genetic tests made available for them.
Can I just mention as well that for some patients with a suspected genetic cause of their epilepsy, if you can identify that cause, then there can be sort of therapeutic implications of that. So particular drugs that are recommended that work better because of where in the pathway the gene is. But that doesn't happen that often these days. Hopefully more in the future.
There's so many interesting things going on, and I think we could keep going for another hour at least, but I'm conscious of time, and we have reached 2 o'clock now. So thank you so much to Ben and Catherine. There's so many interesting emerging areas that we can keep our eye on. Can I just have that last poll question, Elaine? We'll just ask people's feedback about
Yeah, certainly.
Thank you.
Pop it up now for you.
Because we try to cover a lot of ground and just give you a taste of different things, and it'd be really great to hear if there are topics you'd like to go into further detail and have a sort of a longer webinar just focusing on certain areas. So it's just one poll question from us here, just to get your interest in further training. So you can select more than one if there's other things you'd like to hear about. That's good. People are interested in lots of different things. I did have a few slides just to give you some signposting, some education resources, but perhaps I could pass those on to Elaine that might be able to share those with you so we don't overrun too far. But there's incredible resources. Thank you, Elaine. If you want to find out more about what's going on in the world of genomics and the NHS, so I'll pass those on to you so you can find out a bit more. Brilliant. Well, thank you so much for your time. And I hope you found that interesting. And yes, I hope we can run some webinars with you in the future and you'll be able to find out a bit more.